Hello, my name is Peter Schneider. I'm a vascular surgeon from San Francisco, and I have with me two of the most advanced and esteemed experts in the world on asymptomatic carotid stenosis. To my right, I have Dr. Ann Abbott, neurologist from Melbourne, Australia. To my left, I have Dr. Tom Brott, who is a neurologist from Mayo Clinic. And Dr. Brott just earlier today presented some of the results of the Crest 2 randomized controlled trial. This was a packed house, I should say. The interest level couldn't be higher. This has been more than 10 years in the making, probably, since design to fruition of the trial. And I was wondering, Tom, now that the exhilarating moment, I wouldn't say it's past, I would say maybe just started, but tell me, what do you think will be the ultimate impact of this trial on practice? Say you were starting out today as a neurologist, how would you interpret these data?
Well, I think since the last trials comparing surgery to medical therapy for asymptomatic patients, there had been first an increase in the use of surgery to prevent stroke, but then with the advancement of medical therapy, all the improvements and the drop in cigarette smoking, I think there had been a relative dip because people were wondering, with all the improvements in medical therapy, maybe we don't need surgery, maybe we don't need carotid stenting. The results of this randomized comparison of those two techniques to medical therapy really have given us a pretty strong signal that despite medical therapy, high-grade narrowing of the carotid artery at the bifurcation is not a good thing. It's not a time bomb, but it's not a good thing, and it merits attention from, first, we've got the best evidence for stenting, and there's a trend that endarterectomy can also prevent stroke.
Very good. And I want to get Dr. Abbott's opinion, but before I do, let me just say, for the audience, for people that may be seeing this for the first time, if you could just give us just a couple of, maybe a one-liner or two about what the study showed.
The study showed that the medical patients in the stent trial over 4 years had a stroke rate of 6%, whereas the patients in the carotid stent aspect of it had a rate of about 3% over 4 years. That's a 50% risk reduction for stroke. The endarterectomy trial also showed a risk reduction. It was like 5.7% over 4 years in the medical group and a little over 3% in the surgical group. And that difference, which favored surgery, was not what we call statistically significant.
Understood. So, Dr. Abbott, you've been a long-term proponent of best medical therapy, which I think Dr. Brott and I would definitely agree with you that best medical therapy is extremely important. And one of the discussion points about the trial is that best medical therapy continues to evolve. And I think Dr. Brott made the point very appropriately during the session that when they planned the trial, they tried to look forward and say, okay, we should do the best possible thing that we could do, not just for now, but maybe even aspirational, I would call it, how good the best medical therapy was, the close monitoring and everything. In your opinion, do you think they could have done best medical even better than they did? Or do you see it evolving going forward to get better than it is today? What do you think about that?
Well, unfortunately, we haven't seen the paper yet, so I don't have any detail. I can say that the headline results were surprising. This is the first randomized trial that I know of that suggests that surgery is not as good as stenting with respect to lowering stroke risk. So this is puzzling, and I'd really like to sort that out further. I did catch on, I think, that only about 70% of the patients, maybe 8%, got to their target medical treatments by the end of the study. And so maybe about 40% at study entry. So this is not very good. And I do wonder whether ezetimibe was standard with a statin therapy to get the cholesterol as low as possible rather than just aiming for an arbitrary number. But I'd also like to clarify what was the definition of stroke, and are you referring to ipsilateral stroke? So do we have an average annual ipsilateral stroke rate using the same definition that was in ACAS. So that required a clinical deficit lasting at least 24 hours.
Yes, the primary endpoint for the trial was that definition, the World Health Organization definition of stroke. So they are comparable in that regard, with the difference being that ACAS only had CT to ascertain stroke, whereas we, of course, had MRI scan, and we had MRI scan in over 80% of the endpoints. But what we did look at the modern definition of stroke, which is tissue-based, based with MRI imaging, where a stroke could be 6 hours or 8 hours of symptoms if the MRI showed a stroke, an infarct. And we did that analysis as well, and the results were the same, favoring stenting and a trend toward endarterectomy.
So that's ipsilateral stroke that we're talking about.
Yes.
So an average annual ipsilateral stroke rate in medical treated people of what?
Well, it's 6% divided by 4, so that's pretty low.
Yes. So when we talk about statistically significant benefits, is that translating to a clinically significant benefit with respect to patients? I mean, how beneficial is that?
The relative risk, of course, is large. It's a 50% decrease. The absolute risk is smaller, so that you would have to treat 31 patients with a stent with asymptomatic carotid disease to prevent one stroke over 4 years.
Or to be ahead by one stroke, because the procedure does cause strokes as well.
Well, that's a net. That's a net. However, I would say that it's comparable to other treatments to prevent stroke that we use every day, and it's lower in terms of fewer patients to prevent a stroke than medicines like Ozempic or semaglutide.
Yeah, so obviously medical management will change. But and Dr. Abbott, for you, if you have in your clinic population a certain number of patients with risk factors, and you design your thresholds for what you feel is best medical management with respect to blood pressure, LDL, et cetera, what, just to get an idea, what do you think, given that some patients won't be fully compliant, some patients will have either allergies or sensitivities to medication, some people will have other conflicts and problems that prevents them from reaching a certain goal. What do you think is a reasonable threshold for full compliance on all targets for best medical therapy?
I'm not really sure what you mean by that.
Well, will 80% of your patients reach it, or 100% of your patients reach it?
I think it depends also on the risk factor, but I think 80% is still quite low. Because if you're following up patients regularly, I do it in routine practice, I see higher achievements than that.
Okay, well, good for you. Tom, what do you think community average would be in the U.S. for being able to reach the full best medical therapy goals that you set out in Crest 2?
Well, we have some idea. We had 155 sites in 5 countries, and 60% of the patients came in with their LDL above guidelines of 70. And 60% of the patients came in with blood pressures above 130 systolic. So across
So at the
that
beginning,
spectrum,
it wasn't very good, but it did get better due to the efforts of the trial.
And the culture is better today. I think it's better overall, and I applaud getting over 90%.
Yeah, agreed. Question for Dr. Abbott. What do you say about what would be the next study that should be done to further understand this? I realize you haven't seen or read the paper fully, so there may be some subgroups in there of high interest and such, but just going from here, going from what we know about the headlines of Crest 2, what direction would you go in terms of planning the next study? Would it be other factors that could be added to best medical? Would it be a certain specific patient population that you might like to see 2 different therapies compared? Do you have any thoughts on that?
Well, the body of evidence we have so far really indicates that it's very inefficient to go after the asymptomatic patient and try and work out who's going to benefit from the procedure, especially in routine practice where standards are lower for procedures. I think we should really be diverting our attention to symptomatic patients and better sorting those, because we don't have any measurements of their average annual ipsilateral stroke rate on non-invasive care since 40 years ago. And that's because of the huge procedural bias. All these patients just go straight to procedures, and no one bothers to measure their outcomes without a procedure. But I'd also like to ask a question, if that's okay, of Dr. Brott, because as I mentioned, I think this is the first randomised trial to indicate that perhaps stenting is more effective than surgery at reducing stroke risk. So are you surprised by those results, Dr. Brott? And can you think of a reason why this should be it's an outsider type of result that you've got there?
Well, I think that stenting was a baby in 1999 when we started the Crest trial. And now stenting and the cath lab for vascular surgeons, cardiologists, neurosurgeons, and neurologists have been a place where they've been living for 20 years. And so they're better. The technology is better. The stents that were used in Crest 2 are much better than the stents we used in the original Crest. And the stents are getting better all the time. And then there is patient selection. We know more today about the best patients to treat. I was surprised with the overall outcome. I wasn't surprised with the improvement in stenting, given those three factors.
Yeah.
What happened to endarterectomy?
Well, with endarterectomy, I'm not sure. Today we had new data that I hadn't seen before on some late strokes in the European study, ACST2, comparing stenting with endarterectomy. We also had a little blip of late strokes in the endarterectomy group in Crest 2. And I think we want to look into the potential. You know, you're looking at tea leaves a little bit as to why late strokes may be a potential problem with revascularization.
If you, Dr. Brott, if you followed, say you had the luxury of following these patients out for a much longer period of time, say 7, 8, 10 years, what can you predict or imagine what you think would happen with those two curves of repair plus best medical versus best medical alone?
We don't know about best medical going that far out. It would be wonderful to look at. The average life expectancy at age 70 today is 14 years for a man and 16 years for a woman, and we followed patients for 4 years. So that's a big question. With stenting and surgery, we already know out to 10 years that once they're done safely, they're durable.
Yeah, and we'll close up soon, but let me just get one more quick question in for Dr. Abbott. As you look ahead at Best Medical over the next, say, 5 to 10 years, is there anything on the horizon that you're particularly excited about, the potential positive effects, such as GLP-1s or any other lipid-lowering agents, or anything in particular that you see that looks really good to you?
I think it's all about the combined value of addressing risk factors. And I'd really like to see the standard of medical care improve in routine practice. I think that is the big thing. It's not going to be one new expensive drug for a small proportion of patients. It's going to be supplying what the basics are to everyone, what the basics of what works. And that's healthy lifestyles and appropriate medication for risk factors. And that's the big thing.
Very good. And Dr. Brott, any closing comment for this session that we have today?
Just that high grade narrowing of the carotid artery going to the brain is not a good thing. And the three treatments, medical therapy, stenting, and endarterectomy, they'll all get better. And I'm pleased
Over time,
with that.
yeah, good point. Dr. Abbott, any closing statement?
As they all get better, of course, we're getting towards a zero stroke rate, of course, okay? So that means no procedures anymore.
We'll see.
Yeah, could happen. Well, thank you very much. And this has been a super exciting and dynamic day today to have these data released. And I'm sure there will be more subset data at some point. I'm sure everybody has lots of questions that'll be answered by further papers probably. Yeah,
Yes.
very good. Thank you very much.